I think we have all our panelists on board. It's 8 o'clock and welcome to another episode of Marvelous Medicine. This topic was actually suggested by Dr. Patta Radhakrishna months ago. He wanted to get all the emergency medicine heads of Chennai together. So we went a little bit beyond, and we have faculty for you from Chennai, Hyderabad, Delhi, US, and UK. Have a lot of things to convey, so I will not waste any more of your time and hand over to Dr. Arun Nandi, who is going to be the moderator for today. Over to you, Arun.
Thank you, Vidya. Thank you, all participants, all panelists, and the audience as well. This is an amazing opportunity for all of us to connect over a topic that is, I think, of international importance, not just national importance. And I would love to congratulate all of you for achieving everything that you have done so far in your careers, and look forward to your words of wisdom and advice to the rest of us. So without further ado, I must say that we'll have 3 sections in this discussion. The first will start with what is emergency medicine, what are the barriers? The second part will be more operation and structure and staff related. And the last part will be about advocacy, about education and opportunities, so on and so forth. So without further ado, let's plunge in. First section, and we will talk in this about the need for emergency medicine. Why emergency medicine at all? Why not just a casualty? Why not a service line? And let's go.
Over to you, Dr. Ramakrishnan.
Yeah, thank you, everyone, for this wonderful opportunity to interact with everybody. I thank you for giving me time to air my views. The 3 things that we are going to be worried about in our country are heart disease, stroke, and trauma. And these are the major causes of death and morbidity in our country. Now, the way to counter this effectively is to provide timely and effective care. To achieve this, it is very important for us to develop a robust system where the patient is picked up early from the scene of the incident, maybe a trauma or a stroke or a person with an acute coronary syndrome. Care given during transport, triage appropriately in the emergency department. Life-threatening problems are identified early and the proper treatment given. This should actually happen as a seamless effort so that the patients are saved and the morbidity and the mortality would definitely come down. To achieve this, definitely the doctors and healthcare personnel will definitely have to work as a team. And that is why it's very important to have a specialist in emergency medicine. Otherwise, you have pockets of specialists in any hospital. But the problem is care is not coordinated. Each of these doctors are only looking at their specialities rather than giving care as a whole, looking at the patient as a whole. And the emergency physician would definitely fit this role. At the same time, it is also very important to improve care in the rural areas. The way that we can do is to have a very good ambulance services. And to have good ambulance services, not just ACLS ambulance, which is air conditioned with all the monitors inside, but you should have trained paramedics who are actually going to give good pre-hospital care, because most of the rural areas do not have a tertiary care hospital. So patients may have to be shifted to other hospitals. So giving a good level of care during transport is very important. And that brings us to the training and education for the paramedics. Of course, the government has definitely helped by opening emergency care centers and major highways. And the way forward is to give timely care, especially for road traffic accidents. That is my introduction, and I hand it over to Professor Boy to continue. Thank you.
Thank you, Dr. Ramakrishna. And if you see, nicely pointed out by Dr. Ramakrishna, the need for emergency care, robust emergency care, which includes not only pre-hospital but in-hospital care, with a continuity with definitive care. But is it happening right now in the country? Across, if you see, the majority of the population actually lives in the rural belt. And we talk about in trauma, stroke, acute heart failure, sepsis. These are all time-dependent conditions which requires immediate and urgent care in a defined time, within the defined time frame. But most of the patients who are coming to our facilities across the country, actually they are not coming within the golden hour period, which has been defined. If you see golden hour, where the time you get injured for index case of trauma, the time you get injured for receiving definitive care facility should be within 1 hour. That has got a better outcome than patients coming delayed. So, but it is happening, like because most of our patients come in 2 hours, which I call it as silver hours or bronze hours, but that is a reality in the country. But to achieve that, when the patient comes to the emergency department or the emergency room, we should make that first hour as golden for the patient. That is what is called as the first 15 minutes is so critical, whether it is acute myocardial infarction where you need to give thrombolytic agent within defined time period, or you need to do a PCI, or you have a trauma patient that you should be doing a quick primary and secondary survey within first 15 minutes. That is called a platinum period of golden hour. To achieve this, you should be quick, have a team, but is our system geared up for that? So that is what every citizen of this country should actually vouch for getting quality of emergency care. That's why it is you require a team which is on the ground, to actually face the emergency. So that is why it is time sensitive. The more the delay is, the more the mortality is. So if you just finish with one line before my next colleague takes over, is delay in say non-trauma like sepsis. 1 hour delay in receiving the first dose of antibiotic shot increases the mortality by 7.5%. And this is a telling story, of what we received in our country, because despite being the burden of disease conditions, which is reaching the emergency as per ICMR 2017 report, the top 5 conditions like neonatal disorders, ischemic heart disease, lower respiratory tract infection, diarrheal disease, stroke, and trauma killing, the top 7-8 conditions, which has totally changed from last 1 decade, which was mainly related to infectious disease. So that's why this is so important, that we should have a robust emergency care, integrated emergency care system, non-rigid systems in silos. Over to you, Dr. Jairam. Over to you.
Hi.
Yes, over to you.
Thank you, Dr. Boyd. Thank you, Dr. TVR. Now we are reasonably clear as to why we need a ED. I'm going to share, if I can going to quickly share some slides. 1 second.
Radhakrishna, slide share is enabled, right, for all of them?
Yes.
Okay. I hope you can see my slides. Quickly going through, an ideal emergency department should, as Dr. Boyd correctly pointed out, all time-critical emergencies should be managed effectively in the ED. Whatever condition that doesn't need a cath lab or theatre, they should be sorted out in the ED. If we have this definitions clear, we can look at what are the barriers to achieve these. What are the hurdles that we face? Most of them are common to any other emerging specialty. But if you look at it, the key is when we look inwards, look at ourselves and see, do we really have the trained, skilled, and qualified personnel to carry all this out? It's not going to be easy to deal with a fitting neonate one moment, a massive postpartum hemorrhage the next, and MI in cardiogenic shock in the next day. So if you have to do such varied presentations, deal with varied presentations to an optimal level, the guy has to be skilled, untrained, of course. So the other hurdles are this: we just get unregulated ED flow. People, if they can't find a bed in the hospital, they try and route them through the ED. Say, I got a patient who's posted for a laminectomy tomorrow. He's got terrible pain today. Can you take him in? It's a condition I'm sure you all have faced. So non-emergency shouldn't really be routed through the ED because it will really pull down the care delivered to the emergency patients. Exit blocks, if you're keeping them too long beyond what is needed in the ED, again, there's going to be a major issue. Space and infrastructural needs. And it might sound a bit funny, but new corporate hospitals with 300, 250 beds will have 5-bedded EDs, 4-bedded EDs. It doesn't make any kind of sense. And in terms of equipments needed, we need monitoring equipments, we need defibrillators, we need our own ultrasound machines, we need our point of care testing, we need the whole lot. All of that should be available. Co-location of other facilities, radiology being in the same level, cath lab ideally in the same level. Again, we are talking about the time duration. So if you look at it, all of them should be accessible and in the same level. Um, the ED, when you really newly start a ED in an existing hospital, the clinicians would think, what is this guy doing with my patient? The specialist might have such a view. Ideally, the pie is too big, and ultimately everything should be patient-centric, and we shouldn't really be thinking in that direction at all. Winning over the other specialists or getting them to understand that we can do a good job is paramount. EM physicians or generalists or specialists in resuscitation, they should be able to deal with all acute emergencies. So we should allay their fears of, can he do a better job than I can in terms of, say, sorting out an arrhythmia or dealing initial management of a sepsis or whatever. Yeah, so we should win their faith. And the answer is to win them over in the long run with your skills, with your dedication, and with your patient-centric approach. Monetary barriers. Some of the hospital employers, admin guys might think, why does it pay to have a good ED? You can't really measure everything in the balance sheet, financial balance sheets. Good EDs, trust me, would make a lot of financial sense. It's not even to be debated. So I finish with this quote. ED is a thankless job. It's what my consultants in the UK used to say. But I think it takes patience and courage to work hard and not get recognized. Ultimately, we get the best adrenaline rush more than anybody else. So that's enough, I guess. Thank you. Over to the next speaker, please.
Hi, good evening to everybody. I thank Dr. Pata sir and Dr. Vidya for this opportunity. I would also like to share my screen. So barriers to emergency medicine. So what, first of all, there should be change in mindset. What is emergency medicine? Emergency departments need administrating backing. So emergency department is the problematic place in a hospital. And there are bound to be many problems happening every day. And the administration should understand. The mindset should change in the administration. This is a problematic department. Problems are bound to happen because the patients are sick, attenders are very emotional, the doctors are working hard, their adrenaline levels are high. A small trigger can flare up. So no knee-jerk reactions should be there. So often people say emergency department is the face of the hospital, and you want the emergency department to be smiling always. So for that to happen, you should not have a broken hospital system. The emergency department can be smiling for a certain period of time, but if there is a broken hospital system, the smile will fade away. If you want the emergency department to be smiling, the hospital system should be robust. So what is it? There should be freedom for the emergency department to function as a department. And ER staffing is very important. Doctors, nurses, not only doctors and nurses, the other support staffs are very important. You cannot put a junior doctor in the night and claim that you have a good emergency department. Same way is lean staffing, 1 or 2 nurses for night shift or evening shift, and you cannot say you have a robust emergency department. So 24/7, 365 days, there should be senior persons who can make decisions anytime. And as the previous speakers were saying, good pre-hospital resuscitation team. In abroad, if it's a MI patient, they skip the ER department. From ambulance, they directly go to the cath lab. So we are far away from that, but we can work towards that. And again, polytrauma, golden hour, platinum 10 minutes, these ambulance people will be of lot of help. And point of care testings. ER department also has certain tests like a arterial blood gas, like a POCUS, point of care ultrasound. These are tests to make sure that the patient is not sick in the ER. And we should have the freedom to be able to do this test on the patients as we wish. And turnaround time. If there is a delay in the lab test returning, or if there is delay in the radiology, it's going to reflect on the ER's ER's way of functioning. The complaints are going to be on the ER, not on the labs or the radiology department. So to run a good ER, you should have all these things functioning well also. Another thing is length of stay of patients. You should get a diagnosis of a patient within 3 to 4 hours. And the patient should be shifted to the ICU or wards depending upon the condition. The lack of beds there, if there is stagnation in the ER, it is going to decrease the performance of the ER. If a ER is staffed for 10 beds and you have stagnant patients, 10 beds, and you have 2 or 3 more patients coming in, that's definitely going to reduce the ER's performance. So all these things, mindset should change. And consultant availability. Most of the consultants they respond well, but for the physicians, their OPDs are very important. For the surgeons, the theaters are very important. But in ER, all these are going to reflect on the ER's, functioning. So few barriers is, I put a slide that as symphony. You see, you have all kind of musicians playing different musics. So there should be someone to coordinate them, and that's the person who conducts it. You cannot simply say, I am the ER consultant, I'm going to conduct, you come and do this, you come and do that. Nobody is going to accept that. So ER is not easy work. It is hard work. It doesn't happen overnight. You have to do it slowly. So you have to build the trust of consultants. Trust of consultants will be built only if you show and prove yourself, not once, but continuously, not within short period, over a period of time. Over a period of time, you have to show them who you are, what is your ER, what is the capacity of a ER, what are things you can do. All these breaks the barriers, and the consultants understand what the ER can do. And not only a few seniors working together, it is the entire team should be on the toes all the time, 24/7, 365 days. One small mistake and you're back to square one, and you have to build your trust again. And how do you build it? You have to constantly show your knowledge, your skill, and communication, I think, is the most important thing in here. Communicating with the patients, with the patient attenders, and to the other consultants. Most of the time, a good communicating here solves most of the problems. And about loss or profit, I have no idea, but what I can say is a ER which works for the patients, for the well-being of patients 24/7, 365 days, will definitely bring in a lot of patients, and definitely the hospitals will make money. And empathy is one word I tell all my juniors. Have empathy when you see any patients. Empathy to certainly, if it is an unfair thing, you have to be firm and say a firm no. But empathy is very important for the ER team. And one example, I hope all hospitals are making good profit from ER is, otherwise corporate hospitals are not going to have ER departments for fun. Of course, there is patient care. But if you're going to invest in ER departments, I hope they definitely do money from the ER departments also. And this is a slide just to show when was the ER started. So if you see dark one, internationally in US and UK were the first ones to start. The lighter ones lighter shades, our ER started a bit late. In India, it was said to be started in 2009 officially. And the UAE and Gulf region, the ER system was even more earlier started than the Indian system. And I hand over to the next speaker. Thank you for this opportunity.
So, Dr. Nandi, you want to just summarize, and if the audience has any questions, we can take them now. Otherwise,
I think it's a very good place to pause for a few minutes, because I'm sure that this is exactly where we stand today. So some of the things, just to summarize, I'm giving myself 30 seconds to do this like a true ER physician. Time is of essence. So the first thing that came out of this is the fact that is emergency room, emergency medicine a specialty of its own? Took a while, even in this country, to get that recognized. And it is beyond doubt that it is a specialty of its own, because we are, as all of the panelists pointed out, resuscitators and stabilizers. Nobody does it better than us. Hence the concept of the golden hour, and even the new talk of the platinum hour, platinum minutes, in which we have to get there in minutes, not even in an hour. Both for time is muscle, time is brain, time is organ failure for sepsis. Truly and well said. One of the things that needs to happen is a paradigm shift in this direction. The others have very well summarized the barriers. One of the barriers was this acceptance of the ER as a specialty. And I think the last point that you brought up segues extremely well into this, that to win the respect and the trust of your colleagues, you have to prove yourself as good resuscitators and as good stabilizers. In order to do that, you then need the right people, the right structure, the right systems, and the right amount of funds, which is obviously the next piece that we're going to go into. Trust and communication are key. Trust will come, but it won't be overnight. Communication is not just with your colleagues, but also with your patients. And recognition of your colleagues is going to be very, very important. This is a high burnout, decision-dense area, and people have to make decisions sometimes on very little data. And that is the key that of emergency medicine. Hence, you need support. The burnout is high. You need both physical support, but you also need support for people, which is not obvious. The burnout has to be addressed. And lastly, I must say, on value and economics, the ER will not generate money right away, not like a cardiology department, not like a cardiothoracic, neurosurgery, or orthopedics. It will not bring in the dollars and the rupees, but it will bring in patient satisfaction, and that is key. In fact, the government here in the US has recognized that patient satisfaction is such a high factor in determining where they will go to, that in value-based purchasing, 20 to 30% of every person's reimbursement is now linked to patient satisfaction. And it begins, just as you have correctly said, at the front door or the front face of the hospital. And if you don't score right away, the patient can have a wonderful experience upstairs, but if he starts badly, that will always be remembered. I think with this, I would throw it open to the audience for questions from this great panel.
while the audience are getting ready with their questions, if any of the other panelists want to add a word, we can do that. And in a minute or so, we'll go to the next section. So,
may I say something?
Yes, sir. Yes, sir.
Yeah, one of the other barriers besides the barriers towards...
Please keep your camera on, sir. We can't see you.
Yeah. So beyond the other barrier is there is a lack of prioritization that we should have an emergency room within the hospital. With a barrier, mental barrier of any administrator, if you say, especially in our country, is both in, especially in public hospitals, that's why there should be emergency room. Sometimes it is very difficult to convince them within the healthcare facility. So the barrier is also, to have a single person championing the cause. Nobody wants to champion the cause, so there is a barrier among them, and also at the administrative level. The second barrier is a lack of priority to acute care, because every discipline actually had the cream of every discipline is actually the acute care. And over the years, so there was this has been going parallelly. So now a new discipline comes. We say that, hey, we're going to take care of the acute phase so that we can give comfort to you and also take care of high quality resuscitation is actually what emergency medicine means. So there is also both types, the bottom top approach as well as top down approach has to be there, to break the shackles of creating the discipline of creating a quality emergency care. I'm not talking about only discipline, but it is a whole compendium of emergency care system needs to be built. Then only it will work. Only a facility-based emergency room or academic program is not going to change the whole, outcomes in quality emergency care. That is what my another point I would be saying, Dr. Vidya.
Yeah, this is Dr. Ramakrishna. I just wanted to make a couple of points. I think you should, in our hospital, all the codes in the hospital are taken care of by the emergency physicians. Now, that's the kind of trust that the hospital physicians have. And if beds are not available in the intensive care and a patient falls sick in the ward, the patients are immediately shifted to the emergency department, where we can definitely give acute care with regard to monitoring, ventilatory management. So those are the kind of skills that the emergency physician should possess. And that is the only way that you can gain the confidence of the other physicians. And sometimes they say, we are very happy to keep the patient in the emergency department rather than in any other place at the hospital. Thank you.
So if there are no questions from the audience, we'll move on to the next section. And over to you, team 2. Manu?
So before this team starts, just to let you let the audience know that this team is going to talk about the structure and operations of the emergency department, the nuts and bolts of what makes the ER work and how it works.
So I would be touching upon how and what is the structure and how to structure an emergency department in a medical college or a government setup. See, why this is important, why do we need this, is that now since...
Manu, introduce yourself. Manu, please introduce yourself. So we know that you're speaking from a position of authority here.
Yes, I'm Dr. Manu, Assistant Professor from JIPMER, Pondicherry. I am in the emergency department. I did my MD in emergency medicine. So just getting to the talk. So why do we need this? The reason why do we need this is that government has made it a mandate. Ministry has made it a mandate that all the medical colleges, that is roughly around 558 medical colleges in our country, should have a structured emergency department by the end of 2022. So this has been gelled into the minimum standard, minimum MSR, minimum standard requirements for UG curricula. So we all will be have faced with 3 scenarios. If most of these medical colleges and government institute will be faced with 3 scenarios when you are thinking about this. One, either you would have a new space, which very few would have, and that would be a great thing to write on a clean slate. But most of us would be left with either remodeling your existing setup or expanding your existing setup. So, and this brings challenges. When you are thinking about structuring an ED or what should an ED contain, the main thing is it requires huge strategic planning because it should be future ready. And with this current rising volume and rising acuity of patients, it is a huge challenge and there is no right answer to it. But just let me take you through what is basically required or what does ministry tell is the basic requirement. This you should have. So this basic requirement is inside the MSR or the minimum standard requirements of undergraduates. So every emergency department in the country should have at least 30 beds. Now these 30 beds, the older term was casualty, where we would tell that you should have a 20-bedded casualty, which now has been removed. Now this has been a bit retermed as a triage or bar casualty, which would have just 3 beds. Now, the rest of the beds you would divide, rest of the 25 beds, what ministry has told is to be divided into 5, which is like, non-urgent or green beds. 15 of the yellow beds or your urgent beds, and then 3 of your red beds, which is your emergent beds or your research rooms. Now another 6 beds apart from this 25 is to be dedicated to ICU kind of setup, where your research patients would be stepped down before they are shifted to the respective specialties or areas. Now these are the minimum requirements, and along with this, what ministry has told us, you definitely require a point of care setup or a lab, you definitely require a OT, you definitely require a plaster room, you definitely require a isolation or a decontamination area, and you definitely require a MLC area and a police aid post. These are gelled into the every medical college system or every government setup which is going to train the residents. Now this is minimum requirements, but if you are thinking about how to actually have an ED, or why we should have, or why we should think about this structure, is because all the functional or all the problems in the most of the problems in the ED, what I would tell is mainly because of most of the problems is because of the structural problems, and this most of the stalwarts sitting here would agree to it, and designing that is also very important. So how do you design it? So first thing is to understand your requirement, or how many beds you want. So that is what we call utilization projection. So how much are you going to, how many beds actually you should have dedicated to it. This actually comes from data which you have. So you have to look at your volume, peak volume, how many patients comes per day, and this will give you a rough idea of how much, how many beds your ED should have. And then we add on around 10% or 15% per yearly of the patient increment, how much footfalls will be. This is how you design, and you design it in a way that you design it for next 10 years, because you don't get a chance to, redo your departments every time. Now, apart from that, you also should have something called a functional programming, where you would want your ED to be, the areas in your ED to be structured in a specific way, so that it how it should be distributed. Like, you don't want your patients coming from your triage to have a very huge circuitous path to go to a research area, going through all other care areas. So this should be properly planned. So that is where the functional programming comes. And then finally the space programming, where you think about how much space each area should require. All these depends on how much area you have in your department. Now so this is generally how your department should be structured, or what should be required in any ED. But let me just get to few key specifics, like what are the key areas which is required, and what are the things we should be looking at. The main key area, as Jayaraman sir was talking about, is ED is the face of the hospital, and your face has to be very good. So a few the areas which should be there in the front. One is you should have a very great ambulance bay, which should be able to park at least 4 to 5 ambulances simultaneously, and it should be designed in such a way that it is preventing a lot of inclemental weather when patient comes in. And so these are design things which we should be looking at. And the triage is the entry point of all patients to the emergency. So triage should be properly designed, and it should have adjacent to triage, it should have a registration area, it should have a security personnel attached to the triage, and triage should also have a entry to the isolation or decontamination zone, and decontamination area should have a hot or a cold zone. So these are very key elements, but when we design, or when we think about it, we'll think that it is very it's not very important, but ultimately when patients come in, and when you work in an ED, it becomes hugely important. And then after the triage, where we have different zones or your care areas. One of the key areas in your department would be your research area. And designing it is very key, and how to design is also important. It should have adequate space, and it's always best to have inbuilt space designed to the research areas, where you could keep all your equipments, all your research tools required, because this gives your department tools, and all your operations problem would get solved if you have these. Now, regarding other care areas, obviously you would have other care areas, but few care areas which you should be very careful about is your specialized areas. Like you definitely should have a special area for managing your OG patients, because ED should be ready for any patient, like pediatrics, OG, or ophthalm, ENT. So there are certain areas which we overlook, but we would require ultimately, like OG area, like an ophthalm area for a sleep lamp examination, which definitely would require a dark room, and it has to be designed in that way, and ENT area. So all these areas should be there. And another thing when we are thinking about is to have all the areas, or all the care areas should have a oxygen and a suction inbuilt. Why is because when in a functional ED, we do get multiple casualties or mass casualties. And when we do that, these areas acts as your surge capacity. So building that into the ED gives you a lot of benefits when you're faced with those scenarios. And one key thing which we have to understand is, rather than in our Indian scenario, rather than creating multiple areas which is divided in multiple spaces, because that requires again multiplication of your manpower and resources. It is, when you design, it is best to have some areas which are interlinked and which are flexible. So we cannot copy any system. We will have to come out with our own system which is specific to your place, wherever you are working, because these are systems which has to be designed on the basis of your flow, on the basis of your flow and your patient care requirements. And finally, other support areas like your storage spaces, your mortuary or your body viewing area, or your faculty rooms, your resident rooms. These are also key to designing an ED. And I just forgot one thing to tell is that when you are designing a research, it should just be nearby your radiology services or your CT. You should not have any ED which is designed where your sick patient takes say not we don't shift sick patients to the CT, but at least to be in proximity to your research zone. So that you can get your radiology or CTs done as quickly as possible. And I was talking about point of care. So this is one thing which we do require, which was highlighted by Jayaraman sir also, that this is there. But then what we have to understand is that having a point of care lab separate would, instead of that, it is better to have a point of care facility which would be catering to your ED, which is inside the ED, and then getting your lab time down. That would be by doing some QI initiatives would be a great way to, because in Indian EDs, most of the places would be having issues with the space. So ultimately, coming to the end, what I believe is emergency is a hospital within a hospital, and that if we understand, we would understand what an ED requires and what should be there. Can I share a screen to just show one small?
Go ahead, Manu. After that, we'll go to the next speaker. We're running out of time.
Yeah. Can you see the screen? Or
yes.
Is it shared?
Yes.
Okay. So this is what I told about functional programming, where you divide the spaces. Can you see this?
Yeah.
Yeah. So these are the different areas. So this is one of the key projects which I did. So these are the key areas which we would want. And this is what I call space programming. This basically we write about how much space each area requires. And this is what I call the room by room bubble diagram, or your functional programming, where you decide where your spaces should be arranged. So what should come first? This we have to start talking about this, because this requires a lot of planning. So that is it. Yeah.
Thank you, Manu.
Thank you.
Over to you. Sai, you ready?
Good evening, everybody, and thanks to Dr. Patta and Dr. Vidya for arranging such a nice topic about emergency medicine and how to go about it. And keeping in tone with all the previous speakers, actually, my topic is about setting a new ED in a private hospital. So not much difference from a public sector hospital. But
Sai, can you please introduce yourself as well and your expertise?
Yes, sir. Myself, I'm Dr. Sai Surendra. I head the Fortis Hospital at Vadapalani in Chennai. And have about more than about 10 to 15 years of experience in emergency medicine. My topic today will be about setting up a new ED in a private hospital. So initially, as previous speakers already had mentioned, it is all about the first we think about the 4 different arms of a private hospital. That is your funds, infrastructure, your staffing, the mission of the hospital, and the support systems. So if you take about the pre-hospital systems, at first we start about the positioning of the ambulances, number of ambulances, where the hospital is strategically located, which part of the city, whether you are in the heart of the city or you are in a peripheral, and how much ambulances you need, and how is your the business model going to be. Because private hospitals look more about the business model and patient care side by side. It's a two-edged thing, actually. So how many ambulances you need to cater to that area, and what are the other hospitals which have a similar ED? How much crowded is that particular place around? So next, after that, what type of ambulances you need? BLS ambulance and an ACLS ambulances. What are the things you need to structure inside an ambulance? Your monitors, your defibrillators. After structuring the ambulances, then you think about the space given to you in the hospital. There are different varieties of hospital in Chennai and India, but minimum starts from your 25-bedded to 50-bedded to 100 and 200-bedded hospitals. So every hospital definitely right now understands the potential of an emergency department, as my previous speakers have told. Because once you give the patient the most wanted welcome inside the emergency department, that too particularly in the day and the night, actually the patients differ. Person coming to you in the middle of the night will be a definitely emergency patient, but in a day when the OPDs are full, definitely there will be leftovers happening in the emergency department. They will be presenting to you because they're not able to wait in the OPDs. There are a lot of overlaps like that. So you should actually plan an ED in the private setup in such a way that it is at the front entrance of the hospital, and it is easily accessible from the main road or from the road where it is. And you should station your ambulances in such a way. So it is in the front entrance that most of the emergency, the private hospitals or the hospital station their emergency rooms in the front. And you should, the approach towards the entrance of the ED is most important thing, and how the ambulances come and drop the patient, and how the ambulances pick up the patient from outside or from inside, and how it is transported. And secondly, as my previous speaker was speaking, actually, you should have a robust triage system where you should have different color codes and how you are going to handle the patients if there is a disaster or anything. And after that, once the patient enters the triage, how the patient is going to go to the resuscitation room. The resuscitation room is the most important part of an ED. And after that, you will have to design spaces for medical emergencies and your minor trauma, major trauma, and the decontamination rooms. So right now, we have a NABH standard specific for emergency department. Every private hospitals are moving towards getting NABH for the whole hospital. Once they get NABH for the whole hospital, they are focusing on getting emergency department alone separately accredited by NABH. So they have specific protocols in NABH for, they have different markers. That is the door to needle time, the door to balloon time, and return of patients within 72 hours to your ED. And there are about 5 to 6 points where they are taken as indicators of quality in emergency department. So our primary goal inside the emergency department in a private setup is to fulfill these indicators, because quality is a very, very important thing in the private setup. because it will be from A to Z, everything will be monitored because of indicators. So we have a lot of documentation from your nominal register to the staffing. So every shift should have an emergency physician. As Dr. Jayaraman mentioned, a senior ED physician should be there. There should be a senior paramedic. There should be a senior nurse. And so depending on the bed and the nurse ratio, there is to be actually 1:3 minimum in any given ED, or 1:1 if it is a resuscitation area. There should be 1:1. And if it is depending on the area, yes. Can I go ahead?
Yes, please.
So depending on the staffing and depending on the load, see, any private emergency department in the initial years, definitely the crowd is going to be little less compared. So for a private hospital in the starting stages, so every hospital will have specialties joining us in the later phase. Every 1 month, a new specialty will be joining. No hospital can bring in all specialties together. So ED definitely requires ambulance, a good pre-hospital care, funds and infrastructure, staffing, and our mission should coordinate with the hospital's mission and vision. And definitely, as our previous speakers told, instruments and radiology play a very big role. So the radiology department should be on the same floor as the ED, because your door to needle time and your door to balloon time, and in stroke and in trauma and in heart attacks, all these play a major role for interventions, so that the golden hour cannot be wasted. And one more thing is, you have to prepare a robust code blue protocol inside your hospital, because not alone for NABH or JCI, which is the yardstick for any private hospitals, code blue is a very, very important part of any ED, because every ED will be responsible for all the crash carts all over the hospital. So you should be able to take control of all the crash carts in the hospital and make adequate checks, so that the crash carts are adequately filled without any expiry of medicines. And point of care testings, as my colleagues already told. And in the present scenario, everybody will be facing a scenario in the COVID situation, where every hospital will have a separate COVID ED and a non-COVID ED. So there should be adequate PPEs and your face mask, gloves, and specific equipments required for definitely you'll be having a minimum of 1 to 4 bedded ED for the COVID side and the non-COVID side, as India is fast approaching to the third wave. So definitely all these things should be taken into account while planning an ED on a private hospital. Not much of difference on a government or a private or a college setup, but it will be more focusing on NABH and all other aspects. And every ED should have a robust STEMI and a FAST protocol and a trauma protocol. So every ED should have a code trauma or a code STEMI or a code FAST, where more care can be emphasized, and regular meetings should be happening with the neurologist, cardiologist, and all the supporting departments, so that care is enhanced to the patient. So any other things I can add up?
Dr. Diana has a question. Is there any possibility of developing a standard emergency care of system to be developed throughout India?
Yes, I think already it is developed. It is developed by MCI. It is developed by NABH. There are various protocols which actually say, and there is a robust protocol already in the country by MCI and NABH.
Can I add something, Dr. Vidya, then?
Yes, sir.
Particular to this very important question. Very nicely said by Dr. Sai as well. It is one of the components of a complete emergency care system. The answer to this is, recently there was a gap analysis conducted by Niti Aayog across India, across 100 facilities. And we found the gaps in the length and breadth of the country. There are many gaps in emergency care system, both in pre-hospital care as well as in hospital care. So both the secondary and tertiary care hospitals were chosen. And one of the major policy brief right now, by Niti Aayog, that we are going to build a robust emergency care system. There are many pieces that we are in developing stage. Pre-hospital care, we have come to some place almost the 108 service. And the other aspect is we have academic emergency medicine programs, but they are in variable stage. But the government push is there, even investment for the next 5 years, there will be huge investments in improving emergency care system, not only on facility based, madam, but right from the even the rural areas, in the primary care system, secondary care system, and tertiary care, because we know that 70% of our population lives in the rural area, in the hinterlands of India. So that's why this question is very pertinent and being addressed very nicely. We'll come more into when we speak in the third phase, actually.
Thank you.
Thank you.
Dr. Boy, I just want to kind of quickly also ask you maybe later to address, there is a huge divide, as in every country, between the private and the government systems. And how do we bridge the divide between the standards of emergency care, as asked by Diana, on these both sides? And if you could kind of refer to that hub and spoke model that you talked about, rural care versus tertiary and secondary care. We'll come back to that question, but I think it's worth exploring.
Sure. You want me to respond now, or shall I?
Maybe in the interest of time, if you could keep the question on your mind.
Yeah.
We'll talk to the audience.
Sure.
Vidya, is that I would prefer that, but that's such an important point that I think we need to come back to it at some point. Who's the next speaker?
Rajesh, go ahead. Please introduce yourself and about staffing.
Rajesh, you have to unmute yourself.
Rajesh, please unmute yourself. You're muted, Rajesh.
Thank you, Dr. Vidya. Thank you, everyone, for giving an opportunity to have a little chat. My name is Rajesh. I'm the A&E consultant in the North Middlesex University Hospital in London. Good evening, everyone. Right. So I'm going to have a little chat about the staffing structure in the NHS, which is UK. I'm proud to work in NHS, which has got the third largest employer in the world. And we have a robust A&E system here as well. I'm sure everyone will agree with me in joining to say that emergency medicine is one of the fastest growing specialty, and especially in India, I'm really proud to see that it's really growing well. Coming back to my point, a dedicated and committed staff are a must for every emergency department to be a success. So I would like to share a screen. So in NHS, as in every hospital, whether it's a government or private sector, we have a standard system of a staffing structure. So broadly, it can be clinical and non-clinical. Clinical could be a medical staff and the nursing staff. So we used to call medical staff as doctors, but this has recently changed, as you can see down in the tree. We have consultants who lead the department, and we have clinical directors, medical directors, and the divisional directors. And the next grade would be the specialist registrars and the middle grades. So those who go on to a training program on the Royal College of Emergency Medicine, they go on a system of a 6 years training time, at the end of which they become consultants. Whereas there are some doctors who don't want to do a proper training, so they just come and work. They are called middle grades, non-training middle grades. And in fact, they form the backbone of every A&E. And the next level would be the SHOs, which we call the resident officers or the junior doctors. And again, there is a non-training grade and the training grade. As I mentioned before, not just doctors run the department. We have ACPs, who are called the Advanced Clinical Practitioners. And they are a cohort from the nursing staff or the physiotherapist or the pharmacist. When they finish 5 years of registration, they undergo a 3 year of intensive training to become ACPs. And the next one is an emergency nurse practitioner. And these guys run the minor injuries throughout our department. And the next one is the UTC, general practitioners. They see all the minor illnesses and they take the major burden from the main department. As we moved on, we also have the clinical directors, the physician assistants, physician associates, and the medical students. Coming to the nursing staff, we have the director of nursing, we have the senior matrons, practice development nurses who actually do the training and teaching for all the nursing staff. We have the banded nurses, the charge nurses, the senior nurses, and the flow coordinator. These flow coordinators, they check the system and they make sure the patient has the correct treatment within 4 hours from the time of arrival. And they have an eye on the system at all times, and they form a major help to the department. Other than that, we also have the allied staff, which are the acute medical staff, the anesthetic staff, the critical care staff. They don't live in ER, but they are within a minute's call. We have the fast bleep system. So when you have a major trauma call, when you have a cardiac arrest call or a pediatric call, we do the fast bleep and they all come into the department within a minute and then provide the essential care. And also we have the specialist referrals. We have a fantastic communication system. If the patient needs to go to a surgical or a medical or an orthopedic, we call them and then they come to A&E and see the patients. Moving on, and we also have the pediatric departments. So the pediatric department, they have got a special consultant and they got the trainees and the staffing, and they do a lot of good job. The admin team is, we have a managers, we have the service managers, we have the secretaries, admin clerk, domestic supporting staff and security. And so all of this system we have in ED to form as a fantastic department. At all times, we do review the system, and when it's needed, we adjust our staffing so as to adjust what we need. If we have a major incident, we have a separate plan. So the staffing throughout the hospital are called in and they are given separate roles. And then we do the mass casualty or the major incident plans. We also have a dedicated pre-hospital staff, the paramedics, and they're all ALS trained. So the treatment essentially starts from the time the patient is seen at their houses or in the streets. They do the initial treatment and then they do an alert call. We receive them in recess. And so we do the treatments. We also have the healthcare assistants or the phlebotomists, and they do the point of care ACGs, they do the bleeding, they do all the blood tests. And by the time the clinician goes to see a patient, we have all the test reports ready so we can make an informed decision. If there's any other questions regarding the staffing pattern, I'm happy to answer at the end of this session. Thank you all. Thank you very much for listening.
Stop sharing your screen, Rajesh.
That's fine. I can continue with that. I can continue with the sharing. So I'm Dr. Sriram. I'm the consultant in emergency medicine in Global Hospitals, Chennai. So more or less, you would have seen the sharing of Dr. Rajesh. So I worked even in NHS, Gulf, all those places or anything there. So if I crisscross, subtract many things from Rajesh, it comes to the Indian standard. So decrease the number of doctors, decrease the number of nurses, increase more administrative, there comes the Indian standard kind of things. So let me go through there. I just want to know where we are. How can we increase the number of people in emergency? So the emergency people are considered as pre-hospital and hospital. The ambulance services are considered as part of the emergency department. So they are first on scene. They are all almost on the first on the scene kind of things. I've just shared the kind of things. So we have a system, an ambulance number, 108 or some other emergency ambulance number. So each hospital has their own number. There is no uniform standard there. It's a government official number is 108. The ambulance are basically used for transport, not for any real emergencies or anything there. If you look at the emergency cases coming to the ER, most of them is coming by a share auto or a car. In fact, in the bike, like in a movie, it comes to it. So when to use the ambulance and which ambulance to use? The ambulance are basic life support ambulance and advanced life support where they can actually resuscitate a patient. You can start the treatment then and there because they are on the first on scene, and you can actually transport to a nearest and most ideal hospital. They say a trauma where there is no neurosurgeon on there is no point in shifting there. So the idealist one, you should know that. Next comes to the inside the hospital. So we have a healthcare staff, which is there. First on scene will be the triage nurses. Ideally speaking, triage nurses has to be a much more experience. So they can understand the problem. They can evaluate the problem. They can give priority to the patients will be there. Unfortunately, some of the times, with the junior triage nurses or anything there, they can bring a sick patients much more later than earlier. Then comes to the doctors. So some of the hospitals have emergency physicians here. Otherwise, there is only a duty medical officers or anything there. Ideally speaking, you need an emergency physician, registrars and interns. So many people what Dr. has put, Rajesh has put. In a government setup, it's going to be sooner or later, it's going to be like that. Then the trained ER staff. If you look at the ER staff in India, the junior most people comes to ER. The working junior most people comes to ER. Rest of them works anywhere. So they think it's a problematic department. The junior most people will be forced to come there. We train them for a few years, then they move to the other people there. In an ideal world, we need to have a mental health staff, not only for the patients, also for the staffs. Also, ER pharmacist has to train for all the medications kind of things. As all pointed there, the nearest point of them is the scans. ER dependent on the scans. You need a radiographer who can handle the X-rays and CTs are the nearby, and you can get the help for the radiologist. The most important one, let's not forget, the administrative staff, the support staff, who are the housekeeping and the transport persons. In India, the main problem, unlike in NHS UK or anything there, security. The security plays a major role in the emergency department to avoid the problems. Last but not the least, most important person for the for an ED physician is time. Time is the most important friend for an ER physician, where you can treat much more earlier. I would say that think as an ER as a part of the hospital, not thinking as a last one. So majority of the hospital, they build everything. They think where to put the ER. Most of the ER department, if you see that it's more on the corner or the side of the. So ER has to be somewhere in the center where you can coordinate with all the teams, needs to be there. Thank you for giving me time. I've just finished on time. Thank you.
Yeah.
Thanks. Over to you, Suresh.
Yeah. Thank you all. And I think we are on the time now. And first, thanks to Marvelous Medicine and Vidya ma'am for giving an opportunity to be part of the panel. And next 5 to 6 minutes, I'm going to talk about the key indicators for the emergency department. Well, we have discussed about the infrastructure, staffing, which was...
Suresh, if you don't mind, please introduce yourself.
Yes, ma'am. Hello, I'm Dr. Suresh, heading the emergency department at Yashoda Group of Hospitals, India, and Hyderabad, where I'm representing in this panel. To start with, yes, we have set the department. Yes, we had the infrastructure. We had starting from ambulance bay, triaging, and then your research bay, your majors, minors, and then your procedure rooms. Yes, we had all of them. Then how to run this department? It's very important to have a ED lead, that is the head of the department, to be an example for the emergency department. That is one thing. And at the patient level, we can divide into the entry level, evaluation level, and patient exit phase. In these three phases, we can set the standard operating procedures. What are they? They are like defining a process for each activity we are doing as a clinician or for the support staff. What they are going to do, we are going to put down on a paper at each level what their job and responsibilities and their as per the designation. We are going to define their roles so that it would be easy at the end of the day, or if we are seeing the ER footfall, how many have come, and then how much we gave in the best in terms of the patient care, as well as the outcome that is measurable as a patient satisfaction, that we are going to measure through process and standard operating messages. For these, we are going to define the key performance indicators, or KRAs, that is key research areas. We need to define them first. This at the operational level as well as the clinical level. So coming to clinical indicators, just imagine at the triage bay, one patient, like any trauma patient, you triage it as priority 3, but he is in agony. He's in agony in pain. Pain score is 8/8. Are we going to deal with him first? Yes, as a clinician or an emergency physician, no patient should deny the analgesic in ED. So we need to cater him. Okay, we need to give effective triaging, and we need to give the analgesia. Then we can categorize him as priority 3, and then keep him aside. That improve the patient satisfaction as well as the patient outcome. This is one example. Coming to as an emergency physician, what we are doing. So we are going to identify the life-threatening emergencies. Yes, we are going to proceed in ABCD manner, and then we are going to fix the problem then and there itself, stabilize the patient, put the diagnosis, and then handing over to consultant. In these, at each step, we can define the clinical indicators. Suppose one of the life-threatening emergency like ACS, acute coronary syndrome. Here, time is hard. Here again, from the patient entry, there are defined protocols like door to needle time, which is 30 minutes, that we can define. And then door to needle time, that is 90 minutes. These are very much clinical indicators which improve the patient outcome. Coming to stroke, yes, we do have a time here. Yes. From the patient entry, yeah, within 25 minutes, yes, we need to get the CT done. 35 minutes, blood has to be done. So each department has to define the protocol in such a way that to improve the patient outcome as well as to decrease the mortality as well as the morbidity. Here again, door to fibrinolysis time is under 60 minutes. Again, if the patient comes in stroke, like automatically this patient will be categorized as priority 1, and with the set defined process, we can give the what is best to the patient, which improve the patient outcome. Trauma example, yes, we need to categorize here as well. Many patients have the codes. Okay, we have a polytrauma team. So upon the arrival here, emergency physician is going to act as a coordinator and bring in all the subsequent speciality which is going to tackle the patient, which improve the patient outcome. For these, we can define the clinical pathways for ACS, stroke, trauma, all this. Coming to operational level, yes, even it is a public sector or private setup. Imagine there is a huge queue outside. So what is here? At the earliest, if you see the patient, either a senior triage nurse or a junior doctor or ED consultant, based on the scenario, if you attend the patient at the earliest, that improve the patient outcome as well. Coming to within ED, yes, patient has seen by a junior doctor. Then what about ER consultant or any other specialty? Again, we can put the time here for ER consultant response, again, which will improve the patient satisfaction. Coming to bloods, yes, we can have the turnaround time at about minimum 1 hour for all ED patients. Again, that help you to put the diagnosis, which improve the patient outcome as well. Radiology as well, we can just define the TAT for your X-ray or CT or MRI, which again improve the patient outcome. Coming to TAT, overall TAT, yes, patient has come, you have put the diagnosis, yes, you have evaluated well, and you have stabilized, And then at the time of patient exit, there is a turnaround time. I worked with NHS. Again, we do have a 4-hour stat here. Our hospital has a turnaround time of 3 hours, which put you on your toes. Starting from the nurse to ER physician and then consultant, even at the operational level. If you don't stress too much on these stat, but you try to get the things under the timelines, which again put the efficiency of your ER at its best. Okay, I think this summarizes the key performance indicators for the emergency department briefly. Once again, thank you for the opportunity, ma'am. Yes.
Thanks, Suresh. Nandi, you want to round up this section?
Sure. So again, really good overall talk. Thank you all the speakers. I just made a couple of quick notes. One of the things that I always think of the emergency room as 3 sections: the front end, the back end, and then we are in the middle. So the emergency room, the front door is always wide open and the back door is always bolted shut. That's the way I see it. So what happens? The middle explodes. So it's like, what do we do to make sure that the back door is at least partially open? And I think we touched upon this because we have no way to control the flow of what's coming in through those double doors, through the ambulance bay or through triage. So we have to have, and this ties into the last piece that Sriram talked about, the turnaround times. How do you manage chaos? That is the way the emergency rooms function. And that's where lean principles come into actually making sure that not only do we review our key indicators at the end of the month or end of the week, but in real time. So every day, I think to make an emergency department run smoothly and not have the middle section explode because the back end is shut, is to make sure that we are moving efficiently every day, not just at the end of the month and say, well, we did well last month. No point looking at that when the barn door is shut and the horse is bolted. So I think it's very important to know that real-time key operations are really key. And that includes turnaround times for not just the door to needle and the door to thrombolytics and other things, which are obviously very important, but mundane stuff, door to the lab turnaround time, door to x-ray, door to first physician encounter, door to the labs coming back, because these everyday things actually make you efficient. The second thing I want to touch upon, and we briefly talked about this, was decompression of the emergency room. We have to make sure that the back door is open, which means that patients are getting admitted either to an observation area or they are moving up to the floors or to the ICU, wherever they need to go. We cannot have that backing up. And many places, and I think Manu will attest to this, when I started working with JIPMER, we opened what's called the RDU, or the observation or rapid disposition unit, where you can actually take stabilized patient and hold them for a period of 24 hours. This is becoming more and more common in most US ERs. And the emergency room runs the observation unit because you know how well you have to decompress rather than at hospitals. So those are my current thoughts. I think Rajesh talked very well about the staffing in NHS. And then you talked about, the structure the structure is never going to be the same anywhere. And it will depend on local resources to know how well you can staff, whether you're going to have a doctor who is emergency trained or grandfathered in, or you're going to have physician extenders. So that's a topic for another day. One last thing I want to tell you is that we are very dependent on laboratory, lab, and also on radiology. If you need to have a good emergency department, you have to work very closely with these to make sure that they are efficient and responsive to your needs. So that is pretty much my observations. And there was a question from the audience from Dr. Kisku, who said that more than anything else, this is a shortcut for many patients who are able to seek medical care quickly through the ED. Nothing has changed, Dr. Kisku, William, nothing has really changed over many years. This is an illness that I remember seeing the patients from the OPD out flowing into the emergency room or casualty in JIPMER, and I still see it in Mount Sinai. So it's just a question of extent. How well we manage ourselves is key to how we can handle this extra volume. I'll stop on that. We can take some questions here, right, Vidya?
Most of the things in the chat box are comments. There's just one question in the setups in India. Is there a clearly defined distinction between an emergency department and an urgent visit center? I think Manu briefly touched that you should have some space designated to see the routine cases. Do you want to take that question, Manu?
Manu, can you tell us about fast track operations? Because this is kind of linked to that. Lower acuity patients, when we triage them and we see an ESI of 4 and 5, which is emergency severity index 4-5, meaning one resource needed or no resource needed, can they be delegated to a fast track area? I think you've done that very well in JIPMER.
Yes, sir. Yes. So that is one important question, and a right question to ask. And what I believe is that most of the patients who come, probably more than 75% of the patients who come to emergency, are probably walk-in patients or are like ESI 4 or 5, or and they require very little immediate care. But in a setup like government setup or a medical college setup, this is very rampant, and we do have to cater to them still. Why? Because we cannot turn them down, because as everyone was touching upon, we are always open, and we are the only door which always is open. So one thing which helps us is to have a very good fast track system. So we do have this in JIPMER, where we have a patient flow around 250 to around 400 roughly per day. So most of them, around 70-75% of them are really fast track. So what we have understood is that helps us a lot in decongesting our real care areas. And this has tremendously improved. So I do again, suggest to have any ED when they develop to have separate fast track systems, so that these kind of patients could be catered to. Yeah.
Chandra, you want to come in now?
Yes, ma'am. I just have. Am I audible?
Yes.
I have 2 points. One is initially the concept of casualty when it was there. Most of the hospitals, if we can compare the entire hospital to the circulatory system and compare the patients as the so-called impure blood from the vena cava, the right atrium is the receiving chamber for that. So the ER or the casualty was just treated as a receiving chamber, and then they'll just refer it to the next chamber. But today we all realize that ER is not the right atrium. In fact, it is the SA node. It is the sinoatrial node of the hospital. If something goes wrong there, you get arrhythmia, stroke, cardiac arrest, the entire hospital system collapses. So in short, it is the most important structure in the entire hospital system. And adding on to that, the second point is, as Dr. Manu told, it is a hospital within a hospital. Because of which I would say that anyone who has worked as the head of the ER for a few years make very good hospital administrators. I'm looking at it from the management point of view. ER is a breeding ground for very good medical directors and COOs. We leave the CEOs to the radiology department, and I think COO and medical director, ER will be a great fit.
Chandra is protecting his back. Okay. Any other questions or comments? Could you raise your hand? Otherwise, we go on to the last section.
There was a question.
Dr. Nandi's, the last fast track, what is actually being done structurally as a policy in the country is especially fast track by designing the ED. We have designed and for especially the district hospitals, as well as the tertiary care, new EDs, which is going to come up across India. So here the flow, for fast track, we have designed in such a way there is separate area where the flow of the patient will be separate, and exit also will be from a separate door. So there is no mixing. They don't come inside the system, to mix with the priority 1 or 2. So that has been done, Dr. Nandi, as a design in the design itself of the ED for future. And those who are already having existing EDs in the district hospitals as well as in tertiary care, that guideline also we have given the template of a functional ED, because you can't break the structure already existing and back new. So already existing, there is a functional ED plan. We have already made as a policy and is going to be circulated to all existing EDs, especially in the government sector. So, so that is going to help, in actually ironing out these issues, and
That is the only laptop.
Yes, sir.
I think that's a really good point, Dr. Boy, because I think standardizing emergency practices, for example, there was a question from Diana earlier on, can we standardize across the whole of India? I think that is a loaded question because you really cannot standardize everything, but there are certain things that do need to get standardized. Triage, for example, as you pointed out, needs to get standardized following a standard ESI protocol. The value of sorting early so that you do not crowd up the emergency room with things that are low acuity is so important. And I'm very happy that you are in a policy making capacity where you can influence this mindset across administrative as well as political realms, because it is important for people to realize that the emergency room will only function if it is not loaded with things that are not emergency. So having that side track, fast track, super track from the very get-go is so important. And these areas can actually be staffed with physician extenders or people who you don't have to use your most practiced provider in these areas. You can reserve them for your high acuity areas. So very good point, and I'm glad to know it's making progress. There was another question. What was that? Somebody, I'm sorry, I may have interrupted you.
How will be the role of a trauma surgeon in future? Or is it better that a polytrauma patient gets treated by multiple specialists? This slightly off track, but interesting question.
It's a good question. Let's take it on. Who wants to take up this question about
Rajesh, you want to take that question?
The role of the trauma surgeon in the
talk
future.
about the triage. I was going to ask you about this fast track, the triaging system. The more robust it is, you filter all the rubbish that enters your ER. It's a nurse-led in a hospital, especially in our hospital. More than 50% of those who attend ER, they don't have a real emergency. And I'm sure everyone accepts this point. So they are sent home or they're seen by a GP or general practitioner, and they don't enter ER at all. We just recently piloted a project, and we have found that 60% of patients who attend emergency room, they don't have a real emergency. So it's a robustness, the triage nurses, they have the power to send them home from there, or they direct them to a general practitioner, and then they do a good job. This is what I want to tell about this.
I'm going to push back on that, okay? Play devil's advocate here. I'm going to push back a little on that. So in the US, the same thing happens. And we have two things that prevent us from actually sending them to a GP. We do see them. I'll tell you what. First is a rule called EMTALA, which says that any person presenting with any complaint, even if he's sneezing, needs a stabilizing exam by a registered practitioner. This was happening because people were dumping patients. So that's the anti-dumping law. Secondly, it's become really important from a revenue point of view that the ER entertains these patients and is able to charge them. Now, this may differ from country to country because this is a country where people do pay for services. So in that scenario, for revenue stream operations, it's become important to address even the minor cough and cold quickly. It's a quick win. It's low-hanging fruit. So depending on where you are, if you're in a rural hospital where you're getting swamped by patients who are not going to pay you anyway, it makes sense to sort them out and send them away. I know the English system is very different. The US entertains these people because actually they get you good revenue. And lastly, about your point about the person in the front who's doing the triage, very important. You said that it's got to be somebody with experience. And I remember we used to put our most experienced nurse up front because she was a real bulldog. She would not let you in. Having worked in the NHS myself for 8 years, I can tell you, nothing of the sort happens in the US. Here, the system is very lenient. So just two opposing points of view.
Yeah, because we don't have any private hospitals doing A&E, and the only A&E is in the NHS hospitals. And number two is we don't charge them. They just come and get all the treatments free. The government pays for it, so we don't let any rubbish in. However, I agree with your point, Dr. Nandi. We have one of the most experienced clinician, an ACP or sometimes even a A&E registrar who does a triage. I agree with your
So
point.
you have a physician in triage. Now that is something
Yes,
I
we
wasn't
do
going to
have,
clear.
yes.
We've started
Sometimes
this
I do sit
recently.
in triage, and I clear most of them.
Yeah, because you can send
And
people
we audit
home
these
from them.
practices.
Perfect.
See
That's
also see
great.
how many come back. Do they re-attend to the same complaint, or they go back nice and good? So we audit them, and we found the system really nice. And we have a senior clinician, a doctor, and then who sits in triage and rubbish, all this are filtered away.
So Rajesh, other than having a clinician at the triage, you have access to GP 24/7. Is that it?
Yeah, we do have round-the-clock GPs in the hospital inside the ED. And there are about like 8 or 9 GPs on a rotation. They come at different times, and we have a 24/7. And they see all the minor illnesses and the minor injuries. As I mentioned before, they are seen with the ENPs, the emergency nurse practitioners, or lacerations or fractures or dislocations. They soak up all these people away from the main gravity. So we are left to see the rhesus and the major cubicle patients.
Really interesting model. Any comments from the private sector, Sai, or anybody else wants to tell us about that?
Yeah, I think even though we are partly like the American model in the private sector here, where the patients do bring us revenue, I'm very particular that we do not entertain non-emergencies because it just takes down the kind of care that the real emergencies get. It uses up nursing time, uses up spaces, and it just becomes a nightmare. Patients who could otherwise be admitted to the ward, having been seen by a physician, they try to enter through the ED. And as Rajesh said, I do sit in the triage at times, and we try and fob them off directly. I get the operations guys and others, COs and whoever else to say, you need to earn your buck, get them out of here. And it often works.
Dr. Ramakrishna, you want to say something? Please unmute yourself.
Yeah, I agree with what Dava is saying. At least during the till about 4 or 5 o'clock in the evening, we don't entertain patients who are just walking in with a little bit of fever or cough and cold. We send them to the outpatient departments. We don't entertain them there. Maybe after 6 o'clock or 5 o'clock when the OPs are closed, then maybe a few trickle in, but otherwise during the daytime when everybody is there, we don't do that. I just want to add one thing. I think everybody spoke about the disaster. I mean, nobody spoke about disaster planning. I think that's very, very important when you actually are structuring an emergency department. You should have place both for disaster as well as when there's surge capacity or suddenly you get 30 patients who come in with diarrhea and things like that. So you should have an area that is near your emergency department, maybe outside the emergency department where you can actually triage and only where the very sick patients actually get into the hospital. So I think it's very important for you to find space far away from your department for such kind of eventualities that happen. And it's very important to do a study on what kind of disasters can actually happen, especially if your hospital is surrounded by, say, factories, chemical factories, or you're more prone for flooding and things like that. So I think that's one thing that was missing. Thank you.
Any comments from any of the other panelists? Otherwise,
I would like to take one question Dr. Diana mentioned. Like in India, we are unable to follow the timelines because of the financial constraints. But as per Indian law, we are not going to deny any case who comes in shock or any life-threatening emergency. We are not going to charge them as such. Like there is a rule like you're not going to deny. You need to stabilize them, put the diagnosis, and then later we can take a decision whether we are going to keep the patient or not. But we're not going to refuse any emergency, and we can maintain the timelines for any life-threatening emergency or if any patient is in real emergency.
Just one more comment regarding the MCH trauma surgery. I don't really know whether we are actually ready for that. And I'm not sure how many of the surgeons would like to give away a nice splenectomy or a perforation or whatever to a trauma surgeon, So unless we have that mindset, probably it'll take a few more years for that to come. And especially in the private sector where everything is money, I don't think the surgeons would want to give away their pie to any other trauma surgeon. Thank you.
We need to get through the third segment, so we'll come back for discussion after that. So over to you, Dr. Ramakrishna, again for the segment 3.
Yeah, I'm going to talk for a couple of minutes on training and education. Obviously, we need hundreds and hundreds of emergency physicians to run the emergency departments in the various hospitals, in the rural areas, in the private sector. And we can't even, give 1/10 of that at the present strength. There are a lot of training going on as of now. The MD Emergency Medicine, which are governed by the National Medical Council. We have the DNB also, and the MRChem, which is the Member Royal College of Emergency Medicine. All these are programs that are offered in the government, private medical colleges, and in the hospitals. The unfortunate thing is many of them tend to go abroad because they find that opportunities here are much less. The pay is much less. People work here for 2-3 years with us, and then they go away to the Middle East because that's what they want, and they earn quite a bit actually. So unless we improve the pay scales for these doctors, they're not going to stay here anymore. It's also very important for the people trained in emergency medicine to get familiar with ultrasound, using an echo, hemodynamic monitoring. Once you get a good knowledge of all these, it's very easy, and you earn the respect of your colleagues. For example, you have a patient with a road traffic accident and you can do a fast ultrasound and say that, yes, there's free fluid. Patient is very unstable. This patient needs to go to the operation theater immediately. Or you have a patient who comes in sepsis, or you want to do an echo and look at the IVC and things like that. So I think it's very, very important for the emergency physician to acquire skills at doing all these things. Or you must be very adept at hemodynamic monitoring, putting in arterial lines, central venous lines, and monitoring patients in the emergency department. Also, I feel it's time for post-MD specialization in pediatric emergency medicine, which is sadly missing in our country. I think we need more emergency physicians who are trained in pediatrics. And also a very good area would be disaster management. So I hope that more colleges and private hospitals would come forward and start emergency medicine departments and training programs. Thank you very much.
Dr. Davapani?
Yeah, I think this Dr. Ramakrishnan gave a very nice summary of what opportunities people have to get trained in EM. There are the DNB and MD are, of course, the prime qualifications which get registered. MRChem is allowed as an additional qualification to be registered. But I think people should also think about super specialization, as Ramakrishnan was alluding to. So PGM, geriatric emergency medicine, and when acute medicine. So we do have several different diverse specialization options in the West, which should start to develop here as well. Pre-hospital is a neglected brother for the EM. I think that needs to be looked at as well. In terms of career opportunities, there's a huge demand both in our country and overseas, specifically in the UK, in the Gulf. Singapore was open to MRChem till recently. I think you can even do the FRChem from India, even though you can't get a CCT. You can give the exams. Having worked in India, you can go over to the UK and give the exams. So there are many options. They will all be placed handsomely. Let's be very honest. A qualified emergency registrar just after his post-graduation will certainly earn more than the other specialties, say a medicine or a surgical postgraduate is likely to earn. at least in the initial years. So I think it's still attractive, but in the long run, maybe we need to find them decent positions. The biggest drawback is that we lose a lot of them to operations. Lots of them become administrators, or we lose them to critical care. So lots of EM guys are switching to critical care in India. I don't know whether we will have an answer for all that. But nevertheless, they all get handsomely placed. As a EM guy, your future is bright. Thank you.
Dr. Boy, over to you. What can we see details of Government of India policy for the future of emergency medicine, as well as how do we bring emergency medicine to the limelight?
So thank you, madam. And the very pertinent question is, on summing up, is I told you, I just also narrated in my previous deliberation that there was a big gap analysis which was performed. I was the principal investigator in that, and one of the gaps which we found that there is a problem in the emergency care system. There are gaps, and one of the major finding in that study, which included both government and private sector, and including more than 300, there are different strata of hospitals was also taken, medical college, teaching hospital which has DNB program in both private and government sector, as well as secondary care level hospitals, especially the district hospital in the length and breadth of the country. And the major finding was this also answers some of the questions by Dr. Nandi, is the institutions which have had academic emergency medicine and those who are NABH accredited hospitals, both in government as well as in private sector, actually performed in most of the key performance indicator, or most performed well in both structure, process and outcomes of the evaluation tool which was adopted from WHO evaluation tool. So that means that it gives a clear indication where to put the money on. That was a facility-based assessment, and we just now I submitted that report to Niti Aayog. Maybe in few days' time, everybody will get a chance to read that telling report, which also is the first stepping stone of any improvement to know our own problems first. Without knowing that, we'll not be able to prioritize our investments. So that's why this study was very important and telling. And this actually was also a prelude to a big policy which is going to be, which is being planned for the next 5 years in the government of India, especially Niti Aayog, the emergency care section. There is a one-line tagline is there to develop a world-class integrated emergency care system which includes trauma. So this was the main line of that policy, and it includes not only pre-hospital care, and we found out that a major problem is most of the death and disability which were there among these hospitals, what can be addressed, and as also supported by WHO, that if you develop a robust pre-hospital care system and emergency care system, you can reduce 54% of premature deaths among the people who actually have got time-sensitive conditions. So, which is very important statement was given in that. And two aspects. This thing is, we already have almost 20 to 22 states which have got access to good ambulance service, which are non-existent before 2007. There are big bits and pieces within 108 service. It has done a great job. Second is the part is it reduced the mortality rate, especially in maternal child health, which was significant. It was published, from few states like Andhra Pradesh and Tamil Nadu. It reduced that. And the response time, for my international colleagues who are listening and all my national colleagues, was, as low as less than 10 seconds. Like state of Tamil Nadu is doing great, Daman and Diu is doing great, Goa, his response time is very quick. The other part of development of and this can be scalable, scalable across India. Second is the what we have done. Yes, many of them are transport vehicles, but they have access. Every citizen can be, can have access to ambulance service, whether it is a four-wheeler or even bike ambulances are there. Boat ambulances are also running, by different agencies. So there is a positive side of it. Second is, madam, is if you see the pre-hospital thrombolysis, which has been achieved by developed countries. If you see some of the development, they do pre-hospital thrombolysis in STEMI, even in stroke people are doing, but we are not lagging behind. If you see the program in Goa, they have done a great job. In a hub and spoke model, they have done a great job, right from primary care. They are thrombolizing, giving connected place, even in primary health center, they have trained in a hub and spoke. After giving thrombolysis, they are shifting to Goa Medical College. So that is a model, and they supply and en route in ambulance, the paramedics are giving the care. So that is the positive side of Goa, one of the key states, small state. There are many such programs in pre-hospital thrombolysis right now running in the country. With that means there is a lot of development going on. The Save Heart Kashmir program, it is being run in WhatsApp. Thrombolysis through WhatsApp in supporting the primary care physician for giving emergency cardiovascular care. The thrombolysis in stroke program, it is happening in primary health the district hospitals in 7 states of India. I'll tell you, Himachal, it is running. In the private public partnership, they are doing the radiology service. CT scan is being done by private setup, and thrombolysis is being given at the district hospital. So we talk about golden hour, platinum minutes, time-sensitive conditions. It may be bookish all the time, but it is really happening in the hinterlands of India, which needs to be brought out. So this is and it is a joint. As I said, Dr. Nandi was saying how to bridge the divide. So there is a joining hand of private-public partnership in that. The radiology service is being provided to the public hospital, and they are thrombolizing, madam, through getting the remote decision. So these are the 2 key examples of both improvement at the grassroots level as well. One more thing, now coming to this service delivery I'm talking about. The government of this pandemic has done some good thing also. Now they just put the focus back to the acute care across the country. If you see, this is the previous decade, was the decades of infectious diseases. There are a lot of programs going on, but this decade has seen the growth of acute care, including disaster medicine in this country, and it is on the ground. It is happening. Though we are, it is a huge country and many phases of development. You can't see the same development in Northeast what we see in our best states in South of the country, but they are evolving and they are very positive and receptive even at the policy level. So that's why this is a part of service. Second is academics. What is the academic development which we are going to have? Yes, the first gazetted notification, which is a sequelae of this gap assessment study which was done across the country. One of the major takeaway was the inputs which was given by the expert committee to have academic emergency medicine in all medical colleges, irrespective private, public, it should have by 2022. So there is a sword hanging also. Unless you do that, at least create an academic department and then start PG program. The license will, it will be difficult for the medical college to renew their licenses. So we know that it is a tough stance, but this is what has happened. Few quick points, then I'll end my this thing. The second part is the DNB in emergency medicine, and Dr. Nandi was saying how to bring it quality in primary care and secondary care, because most of them they land up in the city where already city hospitals are flooded with, because we have a fragile primary healthcare system. So here emergency care, there is a big initiative by DNB, is also they're doing piloting of starting DNB programs in district hospitals, which are now being upgraded into almost medical college. Some of the identified district hospitals are being upgraded to medical college, which has got all capabilities, only they lack teachers. So they are hiring the teachers, they are linking the student to do thesis in local area, local government or private medical college. They are having a MOU. This they are experimenting in few district hospitals of Andhra Pradesh. Few they are going to start in few district hospitals already. There is a request to the Diplomat National Board, especially from Tamil Nadu. They have shown very progressive attitude, and this is what is happening in emergency medicine. Emergency nursing, MSc program in emergency nursing is coming as a policy across the country. Emergency nursing and nurse practitioner in emergency nursing, which the UK and US they have already. But we are going to start very soon as a policy is going to come. Under this present government, it can happen very fast, thick and fast. There will be EMT, which is as Dr. Dhawapalli said, there is a lack, definitely there is a lack of science. This is coming as EMT, basic, intermediate, and advanced. Structure. I know there is a lot of, till the structured program comes, there is a lot of good work, which keeps coming, but it's going to be more structured. So it is going to come, and there will be a cadre to it. I mean, they can take pride that yes, I am a EMT, proud EMT. Like we have a flight paramedic in US, or other. We keep on giving examples. So we will be giving examples after 5 years, across the board to the neighboring countries as well. So this is what has happened at the policy level, madam. And this thing, and this is actionable policy. It is happening thick and fast. So this is my final comments. And there is a bright future, and I feel that all of us who are there in the panel, then this journey is beautiful from developing casualty to emergency medicine. Thank you.
Dr. Boy, that was an amazing summation of advocacy and policy. I just have to say, I will stress on two things you said, and you covered so much ground. Well, one of the things he pointed out was that the care of the patient is really not centered in the emergency room. It really starts outside the emergency room. So training of the paramedics, the EMTs, giving them the recognition that they deserve is really important. I'm glad you said that. So I also heard, I think I heard that there are training programs that will help with structuring their training. One of the things you also touched upon was the extenders, physician extenders, nurse practitioners, and maybe physician assistants, which I did not hear, because in a vast country like India, the amount, no matter how many emergency physicians we produce, the catch-up is just going to be so hard. So my question to you is, do you think there is a role of training physician extenders and such as nurses or PAs in expanding the care?
I do agree. What you said is the task shifting model. Actually, in the primary care, every task need not to be done by doctors. So there is as you said, this is called a task shifting model. So that also we are going to come out with a task shifting model. We'll define core competency of those nurses and define core competency, and also there will be legal protection to them, because it's very important they should be protected legally, and it is because everybody is on their own when they practice in the floor, because there is also litigation violence there. Another point which you said, sir, is how to improve, the primary care physician, how to, even the MBBS doctor, how they should be skilled in emergency care. So this is a very major step we have taken at the NMC, the National Medical Council, because I'm a member of the specialist board in emergency medicine, both in MCA and DNB, and serve as a technical head to the both of this organization, is when we actually did the gazette notification of enrolling MBBS, whoever starts an MBBS course or a medical college, they have to have an emergency department, number one, and within 2 years, they should start academic emergency medicine program. These are the two gadget notifications we have ordered through that Specialist Board of Emergency Medicine, which I am a member of that. So the major part which you have said, so how revolution will occur in years to come. If you see our medical curriculum, for all our panelists, we have all undergone our medical school in the previous system, before 2019, but we were a theoretical based system in MBBS, so I did my theoretical base, the kids kept on mugging up many things. But if you see the 2019 curriculum, sir, my daughter is recently joined, I was happy to see that curriculum. The first few months they're teaching, BLS. BLS they're teaching. The first thing they're learning is doing the CPR, how to respond to a call, first aid response. So there's a major shift. And another thing which we have incorporated so that they take emergency care seriously is, see, suppose there are many, when they go to clinical side, clinical postings, they learn medicine, surgery, ops, gynae, pediatrics. So we have said that 20% of the questions will have the weight of 20, I think out of 100, at least 20% marks, will be weighted towards emergency, conditions of that particular specialty, say pediatric emergency, something like in medicine, medical emergency, or a trauma. So at least they will focus and read those things, during their MBBS, because the exam pattern is also more practical oriented, practical based. So, and it is now become mandatory that those who are going to do internship, they have to have the skill based, like you have in the other countries. We are going to have, sir, this one. And it will change. After that, you see, within few years, we will have a lot of doctors across, because the next exam is not mainly theoretical. It will be the next exam. And that is a major change they're going to have in a USMLE pattern, the next exam. That is the future, sir. So that is the future that we are bringing more practical core competency to our existing. If you remember our forefather, my father, he was an MBBS, but those days MBBS, they used to learn more practical things. They used to do hernia, simple surgical, they had good surgical skills. But over there we have lagged. But now again it is coming back, sir, because of this change in curriculum. So I am very hopeful, very glad that our next generation of doctors will be more competent than me. At least my daughter will be more competent than me in scale, because I was a medicine specialist and took up emergency medicine, and most of us, and I'm seeing very bright new in the panel also, who are already doing MD emergency medicine. So we're going to have good, future, sir, in this. And I'm sure this will definitely make it in next 5 years, we'll see the change, sir.
Those are some of the, I was looking at that chat box while you were speaking, and there were some really good comments that came from Dr. Shireen, Dr. Diana, about the skill levels, which is we've talked about, that it's not enough to just get a degree, but also practice the skills that, were talked about earlier on. We talked about, Dr. Ramakrishnan talked about ultrasound, pediatric emergency medicine, training in disaster, training in, pre-hospital care. So I think we not only have to just get the degree, and I'm so happy that you're moving towards a hands-on curriculum more than anything else. So I think to Diana and to also Shireen in this chat, I hope this discussion kind of touched on your questions. I will leave one thought to all of you, and you briefly mentioned this about WhatsApp, and it kindled a passion of mine, which is that with a country as vast as India, with such a good telecommunication system in terms of our cell phones, do you think the role of telemedicine is going to help us in sending care to places that we can't reach, or where they can't come to us, but we can go to them through the telephone?
Great, sir. This is a very important and pertinent question. Is the Medical Council of India, nowadays National Medical Council, has already legally approved, because this happened during this COVID pandemic only.
Yes.
I know a few of our colleagues, our director and few of our colleagues, professors from AIIMS and the NMC, they are an expert committee group, and they formulated the legal empowerment of telemedicine in clinical practice. So that they have empowered, they have allowed it to, because of this pandemic, so how to prescribe, medications to the person who is giving you a history on WhatsApp, or this thing on a structured this thing. So both they have legally empowered. What they have not yet empowered is the emergency care. So I also, questioned the committee in that, in one of the group discussions, is of the record, that why not emergency care? It is very important. So this is going to come. See, this policy which you have written, sir, is we have included telemedicine, because if you are talking about thrombolysis in primary care, I gave you examples, like the Goa model, I gave you the Kashmir model. The ICMR is doing in 7 states, sir, 7 states. And Tamil Nadu is also part of that and doing greatly, greatly, very nicely. The tribe project in Tamil Nadu. You see that it is a great model, and it is also scalable to other states. The tribe model, and other states are doing. So how they are doing it? Many people are using through telemedicine. Through this WhatsApp. Many telemedicine platforms, the web platforms, secured web platforms they also have. But best they are doing is through the mobile, sir. Through the WhatsApp, so they are doing. Like Goa model, I learned that they are doing through WhatsApp. There is a 10 sub-center, they have linked it with the district hospital Goa. And the Goa district hospital is linked to the Goa Medical College Department of Cardiology. That is how they are doing it, sir. They have provided, they have an MOU with the government of Goa. The government of Goa is providing them the virus of tenecteplase. Now they are giving tenecteplase. Before that they were giving PPA. The antiplase they were giving earlier. So, and they trained. They did the training part. They provided supplies. They had a MOU in place. They brought all the stakeholders, but both the clinical staff as well as the EMS service and referral hospital to the mentoring was done by the Goa Medical College. And plus, there is a legal, protection to the primary care physician that something will happen, nothing will happen to you, we'll take care of. The government of Goa will compensate for that. That was a big, protection. So that's why the primary care physician used to thrombolize. So that is one of the beautiful model which we saw in Goa. And similar program they're doing in Save Heart Kashmir. I interacted with one of my close friends who is a part of that. They are doing it. And Dr. Padma, our neurologist, is doing the thrombolysis in stroke program in Himachal, district hospital Himachal. They are not coming to the medical college. They are, by the time they reach medical college, it will be 4 hours, 5 hours.
Exactly.
The NEGM article by Dr. Yogesh Jain. Dr. Yogesh Jain published an article in NEGM. Please read that, where he said evidence-based medicine, it cannot actually be practiced. It is highly costly. Even rich people cannot practice evidence-based medicine. But experience-based medicine, by the time you say that we have key performance indicators, but if somebody has a stroke in a small suburban, tribal area in Bilaspur of Chhattisgarh, he's an AIMS graduate, surgeon, went in practicing in the small hinterlands. There are many stories, bright physician working in rural area in our country. By the time they, you say that CT has to be done, has to be read within 25 minutes, get the thing. By the time you should reach within 3 hours of the, of getting the stroke. On the ground, it is not happening. Though. In the ground, yes, in the urban sector we are having. But suppose the telemedicine is there. Suppose we empower this thing. We just see that how much difference we can make. The solution is also there. The problem is there, but the solution is this. If you read that article, it will be showing the actual position. That's why it got accepted in NEGM, that article. So 2 years.
Dr. Dauparni wanted to say something. Dr. Dauparni?
Go ahead.
Yeah, we've been in a private-public partnership with the Himachal government for the last 8 years. Up in the Himalayas in Smriti Valley, we've been providing tele-emergency services to 5 government centers in towns in the hills, right in the remotest of places. We have thrombolized people. I'm talking about even before the laws were clear as to what we can and can't do. And we've cardioverted several. We had a patient in VT, a 40-year-old man who was in ventricular tachycardia. The primary care physician was taking visual orders from us and guidance as to how to cardiovert. The equipment were placed from here. As I said, it was a partnership. That is one side. And we had a dedicated bandwidth and all that, as Dr. Sanjeev Boy was saying. Again, in Tirumala, up in the hills, which is not that remote, but still it's at least an hour away from the other hospitals. We've thrombolized 130 plus patients over the last 7-8 years. We have a cardiac center up in Tirumala, but we do that mostly over WhatsApp guidance, and it's completely done by our emergency team. There isn't going to be a cardiologist in the middle of the night who will be involved for this. So these are our experiences with tele-emergencies, and it's certainly going to be the way forward, because access is a difficult problem in a country as diverse and as broad as India.
And I think the beauty about this this project and this concept is that much of emergency medicine is visual. So you look at a cardiogram, you look at a CAT scan, you look at a FAST exam, and these you can perform a FAST exam. If you can teach somebody to do a FAST exam on somebody, you can look at anything from a globe rupture to a liver rupture. So because there's such a visual field, I feel that we have to connect these two technologies. We have a huge population in the hinterland, as Dr. Boy said, and we have this powerful telecommunications tool. I mean, you go to India, everyone's got a cell phone, and everyone's got a smartphone, not just a cell phone, but a smartphone. So being able to bring these two fields together, that Venn diagram, I think is going to be really important, so that we don't have to bring people to us. We can be there for them without them moving. And I think Dr. Boy and Dr. Dhaval, you've actually kind of touched upon something that I think every person from now on should be thinking of, is that we need to reach them where they are instead of them coming to us. That will be the new golden hour.
May I request all the panelists to just turn on their cameras? We'd like to see everyone.
Rajesh has raised his hand. Vidya, you want to say something? Rajesh from the UK.
A couple of questions I want to touch base. Dr. Strange has asked a question about the role of trauma surgeon in ED. So it all depends upon your case that you see. If it's a single system that you can manage, you can do it. Or if it's a multi-system trauma, you might have to refer to a major trauma center. And another, Dr. Sherin has raised a question about, can a general surgeon supervise an ED doctor? Clearly not. Unless you're trained and you're signed off for competencies as an ED clinician, you can't supervise, but you can do the surgical aspects, but a general surgeon would not be able to supervise ED training. And there's another question about the major incidents. I need to stress the fact that all hospitals need to have a major incident plan in place. As Professor Tivia said, if you have a bus which has collapsed or a 30 patients with diarrhea has come in, so you need to have a major incident trauma plan. All hospitals, irrespective of whether they have an ER or not, they need to have one in place. And there's another question about the curriculum, the Royal College curriculum. Yes, the Royal College of Emergency Medicine has got the pathways and the protocols in place for every hospital in the world to use it, and it's completely authorized. So you can use it, but you can actually modulate into your own hospital or your organization's pathology or pathways, and you're allowed to use it. Dr. Diane has asked another question.
Rajesh, thank you for pointing that out. That's a really important piece of legislation that was also passed by the American College of Emergency Physicians. I'm actually the ambassador for India for the Emergency College, and we recently made available all our protocols. It's called Innovate ED. And if you go to their website, many of these trauma protocols, thrombolytics, stroke protocols are now available for you to see and modify according to your needs. Sorry, I interrupted your thought process. Go ahead.
Oh, that's correct. Yeah, because it's an open website, the Royal College of Emergency Medicine. So there are hundreds and hundreds of policies for everyone to adopt. And you can actually tailor it to your own local hospital policy, and you can use it. And there's another question about the curriculum. So do we have a standard curriculum in India, or do you have a DIP-NB or MD General Medicine? Professor TVR was telling about some MD General Medicine. And I should also say that we have interviewed Professor TVR students from SRMC, and we have actually stolen them into UK, and they are trainees and they become consultants. Thank you, Professor TVR, for your students. So do we have a curriculum? Is it a DIP-NB curriculum?
The three of today's panelists are themselves Professor TVR students. Please unmute yourself, Dr. Ramakrishnan.
So he has given his students all over the world.
That's why I say they don't stay here, actually. As far as curriculum, we have to develop a curriculum for emergency medicine, like in general medicine and orthopedics. It's still not available. in the website as of now. Probably it should be done very soon. I'm sure people are working on that. And the other thing you were saying, can a general surgeon actually teach in the emergency department? The National Medical Council has got guidelines where that person has to work for 2 years, have 2 years of training in the emergency department before he actually becomes a PG teacher. Whether if you're from a specialty of general medicine or from anesthesia or from general surgery, you need to show training of 2 years in the emergency department before you're shown as a PG teacher. So that is how they are ensuring that faculty are going to be there in the various departments, because that is going to be a problem in the various departments when they want to start emergency medicine departments. Where do they go for faculty? So it's very important that training happens in some way or the other. And the best way is to spend time in the emergency department for a couple of years and then learn everything and then be shown as a
So, Dr. Ramakrishnan, does that mean that you have to work in the emergency department or be affiliated to the emergency department?
You have to work in the emergency. You have to work in the emergency department. You have to leave your parent department. You have to work in the emergency department for 2 years.
Do they have a portfolio where they have to sign off the competencies, Professor?
Yes.
I mean, it's nothing official about it. We do have it in our hospital, but competencies are not signed off like that. Are you talking about the staff or are you talking about the postgraduates?
I mean, both the staff who need to be
for the postgraduates,
and
they do have a logbook. The postgraduates have a logbook where the competencies are signed off by the consultant. They have to do a certain number of procedures. Yes, but that differs from each university, actually. We do have that for our postgraduates, yes.
So the issue that Shirin and Diana were trying to address is that, great, we are going to start all these, courses all over the country, but we really don't have faculty because the course did not exist before. And then we will talk about, if you are not accredited to do it, you're credentialed to do it, all that. So that's how this topic came up, because most of the teachers for cardiac anesthesia in India are themselves not so-called qualified cardiac anesthetists. Like somebody else mentioned, we were grandfathered into the system. Most intensivists are not primarily qualified in intensive care because there was no such training available 30 years ago. So that's the state in which emergency medicine is today. So I think that was their point, that, if you go and sign up for an emergency medicine MD or DNB in some place, and actually you're being within quotes taught by people who are themselves not had any proper training, that can be quite demoralizing for the students. I think that's what they were trying to
I
tell,
think that is precisely the reason why the National Medical Council has mandated that 2 years the person has to work in the emergency department before he or she becomes a teacher, actually. So I guess that is the reason why they have given us 2 years after starting the emergency medicine department to start your academic program, because you need people to actually work there and gain the experience before they actually teach. There are many online courses that are happening for emergency medicine, yes, if you want some additional training. But I think the best way is to learn by working in the emergency department and not just looking at your specialty if you want to be teachers.
So,
I think this is not, Vidya, this is actually not a new problem. This has happened in every place where emergency medicine has taken this route. Happened in the US, happened in the UK. As to getting the first nascent faculty is always tough. But I think your point is well taken, Dr. Ramakrishnan. You cannot teach if you have not practiced.
This topic actually was originally Patara Radhakrishnan's brainchild. So, Pata, do you think we did what you wanted us to do, or do we need to have a part
It's
two?
nice to listen to so many stalwarts, actually, from being called traffic policemen to physicians of some repute. I think emergency medicine has come a long way. But having said that, I think I was expecting a lot more, and I think 2 hours is just not enough to discuss, because as Nandi was saying, that the back door is shut and clinicians have a lot of role in having the key for the back door. I'll be very glad if Nandi will come with another session with a handful of clinicians to see are the emergency physicians and clinicians gelling well or not? I think do they find faults with each other? If there are any, how can you sort them out? Because, especially in the private sector, I can, as a surgeon, I can make a lot more money than Dawpalni can. I think there's a limit only he can make. So just to say that emergency medicine career is not that lucrative as it is made out to be. So I think these areas also need to be discussed at another session, and we see that what is your relationship with the laboratories, what is your problems you face with radiology, and how can you smoothen them out. Dr. Nandi.
You're so right in this. This is a vast topic we have tried to cover. And when I started drawing up the agenda for this with Vidya, and I said, we are trying to cover a tremendous amount of ground. And I think I am always open, and I think another more directed session at particular, challenges would be absolutely most welcome. I would be happy to participate and be happy to pull the group together. So by all means, yes, my door is always open. And I'm happy because, this is the first time I've connected with all of you. I've been active in India, in Japan and other places. And a dialogue like this really will lead to more cooperation, collaboration, and exchange of ideas. We're all functioning in our silos, and this is the way to link it. So I have to give kudos to Vidya for bringing us together.
It's been one of our longest sessions on marvelous medicine, and thank you.
Amit Ghosh would like to say something. Maybe he'll take a couple of minutes before we close on. Amit, are you there?
The mic's off, Amit.
Yeah.
Your mic's off.
Can you hear me now?
Yeah, yes.
It's it was a way for me to make money when I came to US, where they paid me like $25,000. I had a wife and a son to feed. And that's where I used my ED posting about a month or two to learn some of the basic skills of stitching and other things, and became got the designation of a moonlighting king. And that's how I made my money. But important thing is, your emergency department is going to be as good as the population you serve in or the community you live in. So we had a lot of question on advocacy and things like that. So the politicians and the medical directors of the hospital have to be rightly intertwined. But what we have seen with COVID and everything else is a huge proliferation and the scope of ED. Leadership, as you mentioned, in all aspects, research abilities, practice, innovation. They are the best in the quality management, understanding chaos and management. And again, artificial intelligence. I think we are limited in India, despite the best efforts, that we don't have an insurance policy where the healthcare is paid by your insurance agents like NHS or even in US. And every patient is close to bankruptcy when they go into an ED. So that kind of catastrophic management puts a limit on how much and with what pressure you can do things in spite of having the best talent. And also the amount of violence in the ED and the phone calls which come to make sure that the right specialists are there when XYZ VIP patients come. These are all limiting factors in India. You won't get the right treatment if the right doctors are not there. That's the fear of people. But I think this is all movement in the terrific direction. The future is extremely bright, but so are the hurdles and the challenges. But you have the right panel of very brilliant, hardworking people who can adopt the NHS system or the US system with even greater clarity in India. So I think if India succeeds in getting some of these things right, the telehealth part and the fascinating job which I've been hearing for the last 2 hours, it's going to be a great opportunity. There is plenty of money. The question is, the people who are working in the ED, are they recognized by your hospital? Are they recognized by your education system, by the dean as important? I'll tell you, our ED chief here in Mayo Clinic at Rochester became the CEO of Mayo Clinic Scottsdale. He almost was the finalist to become overall CEO. So as somebody mentioned, these are very, most of them end up with an MBA or something like that. They do very well. So, and the people who work in ED here, it's much harder to get an ER, and Nandi would clarify with me, to get an ER residency than to get into internal medicine. So these are the brightest people who are challenging. They do a lot of things. So you have to give them, not call them traffic cops or policemen, give them all kinds of things, you know, and they are the face of your institution. Your institution is as good as the ED that works. If the ED is great, your institution is great. If the ED sucks, you're going to be in the newspaper so very often. So how, as leaders of your hospital, you sell the ED and the reputation of the ED doctors and all the brilliant logistics which NHS has, all the different sections working in the ED, how they work together in perfect unison. It's almost like a concert going on. In Mayo, we have that system where you know when the patient is in, how long the patient has been in, when the patient is going on. These are very simple computer programs which are there. So all of these are no longer fashionable or only needed in few places. It is a necessity because you value every life. Every life is important. Every person has a family. Every person who goes to the ED may or may not go back to his family, and that's the responsibility of the ED doctors. So I think this is a fabulous session, as Marvelous Medicine has done. And I thank you, Patta, for getting such a... When I saw the panel of so many experts, one of my things to Vidya was, oh my God, we got this whole panel of superstars. It's impossible to get things done in 2 hours. But I think I still learned a lot. And thanks to Nandi and everybody else.
Well, thank you for your gracious words. I think what we have learned today is that we have to probably have a few more dialogues like this. And COVID has really accelerated a lot of things for us, including telemedicine. And that would be an amazing intersection to explore, in addition to other things that you have all mentioned. So thank you for your kind words.
Nandi actually had to reschedule his on-call for us, and thank you so much. And thank you each one of the panelists who always responded to all my queries. And we even had a mock drill. So ED physicians are always aiming for perfection, and so it was really easy for me to put together what seemed like a big disparate panel. Thank you everyone for joining us. And we had done a session on virtual medicine fairly recently, but maybe some other time we can do a session on virtual medicine and emergency medicine, how they could work together. So thank you everyone for listening in, and we'll meet again next week with another session of Marvelous Medicine. Till then, take care and stay safe.
Thank you, ma'am.
Thank you all.
Thank you.
Thank you.
Thank you.